Thank you, Dr. Amar, for your nice introduction. I would like to thank the committee again for giving me the opportunity as a present as speaker for the latest update about a new proton tyrosine kinase inhibitor, which is a highly selective proton tyrosine kinase inhibitor in a patient with mantle cell lymphoma, whether they are with prior prior therapy of use of proton tyrosine BTKIs or the BTKI naive. This one. So we know that the other types of BTKIs we call the covalent tyrosine kinase inhibitors, and have transformed the treatment landscape of mantle cell lymphoma. We know that there are resistance to these BTKIs in mantle cell lymphoma and other lymphomas, and this resistance mechanism of action is poorly understood. The overall survival following covalent BTKIs therapy is poor. As you can see here in these three curves, the overall survival in different population, the post BTKIs are poor. So PIRTOBRUTINIB is approved in the United States to treat relapsed refractory mantle cell lymphoma after at least 2 lines of systemic therapy, including prior BTKI inhibitor. It inhibits both wild type and C481 mutant BTKI proton tyrosine kinase with equal low nanomolar potency. So in this graph you can see that so as you can see here, the inhibitory concentration is not reached to the for the PIRTOBRUTINIB, and as you can see here also that PIRTOBRUTINIB stabilize the kinase phosphorylation and inhibits the BTK signaling. So in patients with phase 1, phase 2 BRUIN study design, the phase 1 was with escalation and expansion from 25 to 300 milligrams of daily of PIRTOBRUTINIB, and phase 2 they maintain with the maximum tolerant dose, which is 200 milligram Q day. And then after that they end up with primary analysis set for 90 patients, and they enrolled first 90 patients who are enrolled for either phase 1 and phase 2, had a measurable disease, had received prior covalent proton tyrosine kinase inhibitor containing regimen, and had no known central nervous system involvement. In terms of patient characteristics, as we mentioned here, that have equal distribution between histology and good performance status, and also equal distribution in patients with maybe score, while the majority of patients have more or less bulky disease, and the bone marrow involvement are equal in both groups. Median number of prior lines of systemic therapy was 3 lines and 2 or 3 lines including a BTKI or naive BTKI. The reason for discontinuation of any prior BTKI either because of progressive disease or because of toxicity, and the majority of patients were because of progressive disease. The prior therapy lines of therapy were including the BTKI inhibitors, the BTK inhibitors, anti-CD20 antibodies, chemotherapy, and other types of therapeutic modalities, including the transplantation, whether autologous or allogenic. I want to also emphasize about TB53 status, because it's mentioned here, and the Ki67, less than 30% or more than 30%. So the overall response rate in a patient with a PIRTOBRUTINIB efficacy, it was 56.7%, with a majority of patients are PR, and patients who are covalent BTK naive, the response overall response rate was 85.7%, with equal distribution between CR and PR. This slide is a very important slide that I would like to emphasize here, that the age distribution, the patient with younger patient, they have better response, and also the females are more predominant than males. And the term of the MABI score, the patient with high MABI score, unfortunately, they tend to be poor responders, while and the patient with bulky disease also tend to have a poorer response. I would from the different histology, the blastoid or lymphoma also they tend to be poor, although that it was 50%, which is not bad, from the 58.6% in patients with classic mantle cell lymphoma. I want also to put a point in a patient who had prior lines of systemic therapy. A patient who had more than 3 lines, they tend to have better response than patients who have 3 or less lines. And I think because, as we mentioned earlier, there are some patients who discontinued the BTKI because of toxicity. And the other types of treatment like BCL2 inhibitor or stem cell transplant, they don't have any differences. But this is what also an interesting, that prior anti-CD20 monoclonal antibodies and with chemotherapy, patients who receive treatment, they have a better response with overall response rate with 60%, while the patient who has no history of prior anti-CD20 monoclonal antibodies and chemotherapy, they tend to have only 27.3% of overall response rate. As we mentioned here, the patient who stop because of toxicity, they tend to do better than patients who stop because of disease progression. Now, in terms of TB53 status and the Ki-67, which is the TB53 status, it was a patient with positive TB53 status. They have 47.1 overall response rate compared to 57.9 patient with negative TB53 mutation. The Ki-67 with patient who had higher Ki, this is the higher Ki, more than 30% of Ki-67, they tend to have almost the same to the overall response rate, 56. Patient who had less than 30%, they tend to have 66.7. And I would like to mention that this Ki-67, it also comply with what we mentioned in the other arm, which is the MABI score, because the MABI score is, the Ki-67 is an element of the MABI score. Now, in terms of duration of response, progression-free survival, and overall survival, the duration of median of duration of response of patients who have pre-treated mantle cell lymphoma, they had a median of duration of response 17.6 months with a median follow-up of 12.7 months. And progression-free survival was 7.4 months with a median follow-up of 13.8 months. And the term of overall survival was 23.5 months, which is almost 2 years.
1 minute.
Patient, okay, almost finished 2 slides. The patient with naive BTKI cohort, they have 100% on 18 months duration of response, and progression-free survival was 92.3%, and the overall survival was 92.3%, which makes that maybe that this patient have a better response. But remember the difference of numbers in the 2 arms. So, duration of response in patient with Ki-67 and TB53, as you can see in the line here, that patient who had the Ki-67 more than 30%, they tend to have overall longer duration than patient with less than 30% Ki-67. But the progression-free survival, it was only 5.2 in a arm with a case Ki-67 30% or more, and while in 19.5 progression-free survival months in patients with less than 30% Ki-67. In the term of patient with TP53, as you can see here, that almost the duration are almost similar, although it is longer in patients with positive TP53, but progression-free survival, both they have almost the identical, although it is a bit longer in patients with negative TP53. So in the term of toxicity, most of the toxicity are acceptable. The treatment emergent adverse events is, as you can see here in this line, that they have less grade 3 or more adverse events, and treatment-related mortality that almost zero in the other part. That discontinuation was almost only in 3%, while those reduction as a result of treatment-related adverse event was only in 6% of patients. So in conclusion, PIRTOBRUTINIB is approved in the United States. Actually, it was approved this year in January, with a median survival follow-up a time of 2 years. PIRTOBRUTINIB continues to demonstrate promising and durable efficacy in heavily pretreated relapsed refractory mantle cell lymphoma who have been treated with prior covalent BTKIs. But we need more studies addressing a comparison between PIRTOBRUTINIB and other types of covalent BTKIs. And here I conclude, and I would like to thank you all for your attention. Thank you.